Let's see what's shown in this picture. You see, the examiner is trying to demonstrate the conjunctival mucosa. What we can see in the conjunctival mucosa is very, very obvious. This patient has quite visible mucosal pallor. So this patient has a pallor of the conjunctival mucosa. Now, what is meant by the pallor of the conjunctival mucosa? It is anemia. You see, pallor can be seen in the mucous membranes, and this can also be seen in the skin, particularly in the palmar creases and in the nail bed. One can see for the presence of pallor. But the best way to describe pallor is the mucosal pallor, because sometimes in some conditions the skin may be thick and may look pale, but patient may actually not be anemic. So it's better to see the mucosal surfaces. They tell you very much about the state of hemoglobinization of the blood. So you can see the conjunctival mucous membrane, you can see the membranes of the oral cavity. Now, what is anemia? Anemia is decreased red cell mass. The red cell mass is less than normal. But measuring red cell mass is usually a cumbersome procedure and requires more sophisticated equipment. So we use the surrogate markers for red cell mass. For example, we can go for hemoglobin values, the hematocrit, or the RBC count. Now, the problem with all these three is that they vary with the hydration status of the individual. For example, patients who are dehydrated, the hemoglobin or the hematocrit may rise. Similarly, in pregnancy, since the circulating volume is increased, the patient may look anemic. Well, actually the patient may not be anemic. But for practical purposes, we use this hemoglobin, hematocrit, or the RBC count as the indicator for the presence of anemia. Now, what value we use? Generally, it is for the males if the hemoglobin is less than 13.5 gram per deciliter, or in females if it is less than 12.5 grams per deciliter for the adults. So this we call as anemia. Now, what are the causes of anemia? The causes can be an acute anemia or it can be a chronic anemia. Now, what is acute anemia? Anemia which develops rapidly, and chronic anemia which develops over a period of weeks to months. Now, when you examine the patient, you may find the patient with acute anemia may be having jaundice or may not be having jaundice. Similarly, patients who got chronic anemia, they may present with anemia and jaundice, or they may be without jaundice. So you have to look. Now, how do you decide this is acute anemia? So if the patient has acute anemia, this body is generally not ready for this acute insult. So the compensatory mechanisms are not in place as yet. So the patient will have a lot of lethargy and weakness. There will be palpitations. Patient will have shortness of breath. Exercise will not be tolerated at all if there is significant anemia. While in chronic anemia, the compensatory mechanism have come into place. For example, the cardiac output has started increasing. The heart muscle starts getting hypertrophied, and it's easier for heart to pump in the blood. The capillary bed that starts increasing so that more circulation goes to the organs, and then there is a change in the 2,3 dpg concentration of the RBCs. So at the tissue level, more oxygen is released. So all these compensatory mechanisms they develop, and the patient does not have a lot of symptoms of anemia if it develops over a long period of time, since the compensatory mechanisms have time to come into play. And only if the hemoglobin drops to a very significant level, patient may have symptoms despite having chronic anemia. So in acute anemia, the patients tend to have symptoms earlier. Then acute anemia, you see, as we said, it may be with jaundice, it may be without jaundice. The anemia without jaundice is usually because of bleeding. So acute anemia which develops and the patient does not have any jaundice is usually because of bleeding. The bleeding most often is from the GI tract. It's either a esophageal varices, the peptic ulcer bleeding, bleeding because of the ulcers of reflux esophagitis. Patient may be bleeding from gastric cancer. Patient may be bleeding from hemorrhoids. Patient may be bleeding from colonic CA. Patient may be bleeding from the ulcerative colitis. So the patient may be bleeding from the GI tract, or sometimes the patient may also be bleeding from the genitourinary tract, particularly in the females who are having polymenorrhea. So the patient may have anemia because of the bleeding from the GI tract or the genitourinary tract. While patients who present with acute anemia and jaundice, the reason may be patient has acute hemolysis. The hemolysis may be caused by infection, for example, malaria can cause. Similarly, the hemolysis can be seen in mycoplasma infections. In some of the viral infections, we can see hemolysis. The patient may present with acute hemolysis and anemia. Certain drugs, they can directly cause anemia. For example, hydralazine can cause anemia. And then patients who've got glucose 6-phosphate dehydrogenase deficiency, in these patients, certain oxidant injuries, for example, certain infections, certain drugs like sulfonamides, and similarly some of the foods like fava beans can result in acute hemolysis, and the patient may present with jaundice and there may be anemia. And then there is a condition called PNH, that is paroxysmal nocturnal hemoglobinuria, that can result in jaundice and anemia, and microangiopathic anemia. Microangiopathic anemia is that when the circulation in these small vessels like capillaries is abnormal because of certain disorders like DIC, that is disseminated intravascular coagulopathy, the patient may have microangiopathic hemolytic anemias. So the patients with acute anemia may be with jaundice or without jaundice. The patients who are without jaundice, they usually bleed from the GI tract or the genitourinary tract, and they have anemia but they don't have jaundice. Patients who have got jaundice, they've got hemolysis. And hemolysis may be because of infections, this may be because of drugs. Direct drugs may be causing direct hemolysis, or they may be causing through in patients with glucose 6-phosphate dehydrogenase deficiency, microangiopathic hemolysis, and PNH, which is a malignant disorder. And similarly, patients who got chronic anemia, they can present with jaundice, they can present without jaundice. So patients who present without jaundice, they may have micronutrient deficiencies, for example, iron deficiency, B12 deficiency, or folic acid deficiency. They may have occult bleeding which is causing anemia, and this occult bleeding is usually going to lead to iron deficiency anemia. The patients with chronic anemia may have anemia without jaundice. The patient, those who got bone marrow failure or bone marrow replacement, that is, patient may have aplastic anemia, or the bone marrow is replaced by some cells, for example, leukemias, or there are other deposits like metastatic deposits in the bone marrow. They may cause anemia, and bone marrow being fibrosed, that may result in chronic anemia, and most of the time is without jaundice. Sometimes in leukemias, the patient may also has hemolysis. So the patient can present with jaundice as well. And the patients who have chronic anemia, they present with chronic jaundice. They may have chronic hemolysis. Chronic hemolysis is going on because of multiple defects. For example, they may have membrane defects like hereditary spherocytosis, hereditary elliptocytosis. Similarly, they may have hemoglobin defects like thalassemias, sickle cell anemia. They may have autoimmune hemolytic anemia, and as I mentioned, some of the patients with leukemias or lymphomas, they may be having hemolytic anemias. Those they may present with anemia and jaundice. Now, what are the risk factors for anemia you should look for? Malignancies, family history, alcoholism, GI bleed, patients who are totally on vegetable diet, African American patients, and the patients of Mediterranean descent. One should look for the presence of these factors. They may be contributing to the development of anemia. For example, patients who've got Mediterranean descent, they may have more of thalassemia and sickle cell anemia, particularly the Africans. Then, as we already described, what is anemia? Anemia is a low hemoglobin and low hematocrit. If the hemoglobin in males is less than 13.5 grams per deciliter, or in the females it is less than 12.5 gram deciliters in the adult population, this is anemia. So when we examine the anemia, we can see patient may have a low mean corpuscular volume anemia, normal MCV anemia, or high MCV anemia. MCV is mean corpuscular volume. So patient may have low MCV anemia, normal MCV anemia, and high MCV anemia. Now, what is low MCV? If the RBC is smaller than 80 femtoliters, this is microcytic anemia. Now, the microcytic anemia, the most important reason is iron deficiency anemia. Then you got thalassemias. Anemia of chronic disease can also present as microcytic anemia. Then sideroblastic anemia and lead poisoning, they can also present with smaller RBCs. Then normocytic anemia, if the red cell size is from 80 to 100 femtoliters, this is a normocyte. So normocytic anemia can be with hemolysis and can be without hemolysis. Patient who've got normocytic anemia and they have no hemolysis, this can be iron deficiency anemia at sometimes. Then anemia of chronic disease, chronic kidney disease, patients who've got aplastic anemia, and patients who've got bleeding and they have non-hemolytic normocytic anemia. Then you see in hemolytic anemias, the patient may have this hereditary spherocytosis, patient may have PNH, G6PD deficiency, pyruvate kinase deficiency, sickle cell anemia, and hemoglobin C disease. So all these can present with normocytic and hemolytic anemia. So we described that even the microcytic anemias, they are iron deficiency anemia. But you see sometimes the iron deficiency anemia can be normocytic as well. So for the evaluation of anemia, we have to consider a lot more parameters. Simply MCV sometimes does not help us in identifying what is the possible cause of this patient's anemia. Then hemolytic anemias can be because of microangiopathy. We already discussed. Patient may have macroangiopathic hemolytic anemias. Now, what are these macroangiopathic hemolytic anemias? We discussed the microangiopathic hemolytic anemias are because of destruction of the RBCs in smaller blood vessels. But sometimes blood which is being ejected in the larger vessels can result in hemolysis. For example, if the patient has aortic stenosis, the blood is pumped under very high pressure. So this causes turbulence in the blood flow, and this turbulence sometimes can result in breaking down of the RBC. Similarly, patients who've got prosthetic valves of metallic type, they can have this macroangiopathic hemolytic anemia. Then patients can have autoimmune hemolytic anemia, which may be idiopathic or which may be secondary part of some other disease. For example, part of leukemias like chronic lymphatic leukemia or chronic lymphocytic leukemia. Then we got macrocytic anemias in which the size of the RBC is greater than 100 femtoliters. So in this you can have a non-megaloblastic anemia or you can have a megaloblastic anemia. Megaloblastic anemia, the characteristics are B12 deficiency anemia and folic acid deficiency anemia. Sometimes you can have copper deficiency anemia or orotic acid urea. Then you got drug induced, which may be megaloblastic, like the anemia caused by allopurinol. And then you got non-megaloblastic anemias. Patient may have non-megaloblastic large size anemias in liver disease, in alcohol use, in hypothyroidism, in Diamond-Blackfan syndrome. So these cells are usually large, but they are not megaloblast. Megaloblast means the maturation is arrested in the earlier stages of development of RBCs. So these are megaloblasts. Now, what is the presentation of anemia? Presentation, the symptoms are patient depending upon the severity and the speed of onset of anemia. So patient may have weakness, maybe fatigue, the patient has dyspnea on exertion, sometimes patient may have angina even in the presence of normal coronary arteries, and the symptoms of individual cause of anemia may be present. For example, if the patient has an autoimmune disease, patient may have autoimmune hemolytic anemia, and there may be features of autoimmune hemolytic anemia. Or if the patient has anemia of chronic disease like rheumatoid arthritis, or if the patient has chronic renal failure, so symptoms of those individual disorders may also be present. But the general features of anemia itself are its weakness, fatigue, there may be shortness of breath, and sometimes there may be angina as well. The signs when you examine, as we saw, the first sign, that is patient may have mucosal pallor. Patient may have tachycardia because the heart starts compensating and the heart rate starts rising. There may be systolic flow murmurs because of a high cardiac output and high flow of blood through the heart. We may have functional murmur, and there may be features of individual disease. For example, there may be jaundice because of the hemolytic anemia, there may be koilonychia in iron deficiency anemia, or there may be absent ankle reflexes in cases of B12 deficiency anemia. So the patient may have peripheral neuropathy. So examination for anemia generally is the patient has pallor, there may be tachycardia, and there are flow murmurs. And then we may have signs of individual disorders. Now what's the initial assessment? What we go for is, we go for hemoglobin, hematocrit, the mean corpuscular volume, the reticulocyte count, and we look at the peripheral smear. So that is an initial workup for the patient who presents with anemia. Now a patient may have microcytic anemia. In microcytic anemia, we would like to examine what is the ferritin, what's the iron, and what is the TIBC. In macrocytic anemia, we go for red cell folate and serum B12 folate. Red cell folate is not available in most of the labs, so it sometimes may be that we use serum folic acid levels. But the red cell folate is the actual parameter which tells us the state of the folic acid deficiency. In normocytic anemia, we can go for Coombs test, iron studies, bilirubin, inflammatory markers, and we can go for the renal function testing as well. Now also screen for malignancy and haptoglobulin level to look for the presence of hemolysis, and the stool goic for the presence of bleeding disorder from the GI tract. For example, a malignancy may be bleeding, colon may be bleeding slowly and producing iron deficiency anemia. Now, when we see the microcytic anemia, we see the iron deficiency anemia. What happens in iron deficiency anemia? The serum iron is low, the serum ferritin is low, and the TIBC is high. When we calculate the transferrin saturation, we find the transferrin saturation is also low. So in iron deficiency anemia, serum ferritin is low, serum iron is low, and the TIBC is usually high. And we calculate the transferrin saturation, this transferrin saturation is usually low. But similarly, we see in sideroblastic anemia, what happens? The ferritin and iron is high, but the TIBC is low, and we calculate the transferrin saturation. This transferrin saturation is usually high. Maybe it is 40% or 50% or even more. While in iron deficiency anemia, it's generally less than 20. In thalassemia, we can see a very low MCV. There may be a high RBC count. This may be disproportionate to the amount of hemoglobin. Patient may have evidence of hemolysis. The patient may be jaundiced. There may be enlargement of the liver, and there may be enlargement of the spleen. The typical appearance of the chipmunk faces of the thalassemia can be seen, and we can go for hemoglobin electrophoresis that can tell us that the fetal hemoglobin is increased in these patients. Then in lead poisoning, we see the basophilic stippling in the RBCs. There is increased free erythrocyte porphyrin. This is diagnostic that patients may have lead poisoning. Then if you see in the initial screening, patient has macrocytic anemia. So we go for B12 and folic acid deficiency, and we see B12 and folic acid deficiency. The features are there are macroevaluocytes. In B12 deficiency or megaloblastic anemia, you got macroevaluocyte, while in other large cell anemias, these cells are spherical, they are not ovelocytes. There is anisocytosis, poikilocytosis with hypersegmented neutrophils, and the platelet count may be low. So we go for examination of this. And you see we do methyl malonic acid. Methyl malonic acid can help us to differentiate between folic acid deficiency or B12 deficiency, but usually it's decided on the serum B12 or folic acid levels. But if there is a confusion, we can go for methyl malonic acid. It can differentiate between B12 deficiency and folic acid deficiency. The methyl malonic acid is high in the B12 deficiency anemia. Then patient may have hemolytic anemia, which may also be mechanical, and there is immunological anemia. So the patient has increased MCV, the LDH is increased, and there is increase in unconjugated bilirubin. So what will happen? RBC will break, the hemoglobin will be metabolized into bilirubin, so the unconjugated or indirect bilirubin starts rising, and if there is a free hemoglobin in the blood, it combines with haptoglobulin, the haptoglobulin will be diminished. So there is increased MCV, the LDH is increased, unconjugated bilirubin is increased, while the haptoglobulin is decreased. There is increase in the reticulocyte count, and you may go for a positive Coombs test, so we can go for a direct antiglobulin test. Then have a history of, if the patient has taken phenytoin, phenobarbital, methotrexate or sulfonamide, they can cause this macrocytic anemia. Then you can see if a patient has pure red cell anemia with triphalangeal thumb and a webbed neck, this may be diamond blackfan syndrome. And when we see the normocytic anemia, you see, look for the presence of anemia of chronic disease and anemia of renal failure. So we go for the examination, we find the ferritin is high, the iron is low, the TIBC is also abnormal, it's low, and we got high transferrin saturation. And there may be abnormal inflammatory markers. For example, the ESR may be very high, the CRP may be high, and we can check the renal function test to rule out renal failure. Then patients who've got normocytic anemia, they may have G6PD deficiency and they may be hereditary spherocytosis. So we can look at the slide, the spherocytes, and similarly we can do the G6PD levels. Patient will have low haptoglobulin, they will be high retics, they will be high LDH, they will be high potassium, they will be high indirect bilirubin. In cases of hereditary spherocytosis, there is splenic enlargement, and sometimes we also see gallstones on doing an ultrasound because of the continuous hemolysis going on. Patients tend to have calcium bilirubinate stones. Then if the patient has autoimmune or mechanical destruction, for example TTP, hemolytic uremic syndrome, or DIC, the patient will have low haptoglobulin because hemoglobin will bind with it, bone marrow will react, so you'll have high reticulocyte count, RBCs break down, they release LDH, potassium, and the indirect bilirubin or unconjugated bilirubin starts rising. And in cases of mechanical destruction, you may have fragmented RBCs. And for autoimmune hemolytic anemia, you can go for direct antiglobulin testing. Patients who've got bleeding and aplastic anemia, the anemia is usually normocytic and normochromic. If the reticulocyte count is high, this is anemia because of bleeding, because bone marrow is reacting. But patients who've got aplastic anemia, the reticulocyte count is low. So if the patient has anemia, normocytic anemia because of the bleeding, reticulocyte count will be high in case of bleeding and it will be low in case of aplastic anemia. So this is how we proceed in patients who've got anemia. And in our other lectures, we will discuss the individual causes of anemia. For example, what are the features of iron deficiency anemia, or what are the features of B12 deficiency anemia, or what are the features of autoimmune hemolytic anemia, what are the features of congenital syndromes of anemia, for example, spherocytosis or thalassemia or sickle cell anemia. So this is about the outline of anemia. So we close our discussion here, and next time we'll come up with another lecture on anemia.